Okay, we still have people joining us, but it is slowing down a little bit, and to respect everybody's time, I would like to go ahead and get started. The meeting is being recorded, so if anybody is running late and wants to go back and listen to the beginning, we will have it posted. So I'm going to get us started today. My name is Candace Bailey. I'm the HCS Division Director. Today is Tuesday, February 11th. Which, full disclosure, blew my mind this morning because I was like, it's like February 1st. It is not. So, all right, today we are actually going to talk about the Nurse Assessor program. And really the point and the goal for today is to do a high-level overview to help everybody understand what this is, what this means, and really give us an idea of where we need to go with next steps, where we need to provide more information, where folks are really wanting more information around this program. So next slide for you, please. All right, so there's a lot of pings because there's still a lot of people joining. As I mentioned, we are recording this webinar, so it will be posted. We are going to be using the chat feature, and we will get through as many questions as possible. Please note that we will get every single question down. The slides are posted. They're live right now, and folks will put the link in the chat for me because they're so kind. If you are listening by the phone and you have a question, *6 to unmute your line or *9 to raise your hand. That's probably the best way to go so that we can then call on you as necessary. Next slide, please. Just a reminder of our mission here within Colorado Healthcare Policy and Finance. Our mission is to improve health equity, access, and outcomes for the people that we serve while saving Coloradans money on healthcare and driving value for Colorado. So here's the purpose of our meeting today. Really, it's to communicate and engage with you all, our stakeholders, about the purpose, so the reason for the assessor, and the next steps there. All right, so we are going to move forward into the next slide here, which is really going to be the beginning of all of the important information. Okay, so the Nurse Assessor program, why are we implementing this program? It is really a streamlined process for members for them to be assessed for their skilled care needs. We submitted a budget request called R10. It's linked there. We can post it here as well. Back in 2023 to receive the appropriate funds to implement this program. The Nurse Assessor is going to eliminate any conflict of interest that currently exists by having a particular provider assess for needs that they then bill for. And so the idea is that a member can actually receive one assessment at a single time instead of potentially having to go and receive multiple assessments. So for example, a provider may only actually provide services for certified nursing assistant, CNA. And so that provider is only going to assess for CNA services. We're going to submit a prior authorization request for CNA services. Even if there are additional needs around nursing, private duty nursing, for example, that provider is only going to be focused on that one particular service. And if a member has additional needs, they will have to go and receive different assessments. The Nurse Assessor is really going to create a holistic, streamlined approach for members so they can have one assessment instead of multiple. The Nurse Assessor is also going to be responsible for providing education around the totality of the services that are available. So they will help inform the members and their families around the different nursing that's available, certified nursing assistant, and also self-direction. So one of the really exciting things is starting July 1st with Community First Choice. Anybody that qualifies for Community First Choice is actually going to have access to self-direction, which is really, really new and really, really exciting. And so we really want to make sure everybody understands this option, and if it's a good fit for them, that they have the option to use this should they want. And so the Nurse Assessor is going to provide that education on the front end for all members. Next slide, please. So just as I mentioned, this really is a holistic assessment for members and the entirety of their skilled care needs. Instead of focusing on just one particular tiny, small area, it really is running the gamut of everything for all of the skilled care needs for a member. from certified nursing assistant to private duty nursing at one time. The nurse assessor may make referrals to other resources, so they may refer members to the regional accountable entity if necessary, the case management agency if necessary. So they really are going to be able to help guide and support a member in receiving and accessing their care. Next slide, please. And there are not a lot of slides today, and the reason for that is to allow for everybody to ask questions, for us to kind of go back through any of the slides that you want us to go back through. As I mentioned in the beginning, this really is a high-level overview of the entirety of the process. So how is this process going to work? So as you can see with this really neat arrow here, the member is going to have some needs. There's going to be some skilled care needs, and then a referral is made to the nurse assessor vendor. So we are going to have a vendor that will provide these nurses, and they will be nurses, to conduct the assessment for each individual member. The referral can come from a family, they can come from a member themselves, it can be a case manager, a home health agency, a hospital discharge planner, you name it. The idea is that a referral can come in any different way that is necessary, and any way a member might potentially receive a referral for skilled care services. So the vendor is going to be required to accept the referral from all different avenues in a variety of different ways. The nurse assessor will have a contractual requirement to set up the assessment within a specified time frame. So all of this, I'm stating this in future state because we don't have the contract yet. We don't have the vendor identified yet. We are in the process of all of those pieces, but none of that is final at this point in time. And so that is why all of that is future state for right now. Next slide, please. And to continue on the process and how it will look, the nurse assessor is going to meet individually with the member or their family, both, if the family chooses to participate face-to-face, so this will be in person or virtually. They're going to use the newly developed skilled care acuity assessment, and the nurse will then, after conducting the entirety of the assessment, will send a recommendation of hours for the services to the member, their case management agency, if they have one, and their home health agency, if they have one at the time. The assessment itself is made up of several components that is used to assess for long-term home health certified nursing assistant, or CNA, long-term home health nursing, so RN, health maintenance activities, which is the self-direction option, the skilled care component of that, or private duty nursing, and. If there are some non-skilled needs, so things that don't meet that level of certified nursing assistant, then the nurse assessor will complete what is called the direct care calculator. So they will also help with that component as well, because not all care, not all assistance with ADLs is skilled care. Some of it is, you can have somebody come in and assist, or you can self-direct, have somebody come in and assist, and there's not necessarily a skilled component to it that would make it that level of a medical care that is needed. All right, so let's go ahead and go to the next slide. I know that there are a lot of questions coming in. So I'm going to pause here and see, Cassie and Aaron, are there any questions on those previous slides you would like me to address right now?
I don't think so at the moment. I think we'll get to a couple of these things. There are some questions on what's the ratio going to look like? Will these be done in person, virtually? And I believe we'll get to those. So I think we can hold tight for now.
Perfect. Thank you very much. All right. So let's take a closer look, as it says here. What to expect during the visit. The nurse assessor. So the nurse assessor is a nurse. They are a clinical nurse that is going to be conducting an acuity assessment of an individual's needs. They're going to discuss things like medical diagnosis, medications, equipment that's used or needed, and a variety of care needs. They'll determine the tasks and the skill level required to meet the member. So thinking, the Nurse Practice Act and the things that fall within the scope of practice for the individual. So there are certain things that fall within a scope of practice for a nurse versus a CNA. And those are the types of things that the nurse is well versed on and will be able to help determine where those needs fall within that scope of practice. If there are any non-skilled needs identified, as I mentioned on the previous slide, or if the member chooses health maintenance activities, HMA, which is the self-direction option, the nurse will then complete the direct care calculator. So during this visit, the nurse is going to provide education on all skilled care benefits, so all of the options for a member, not just one, all of them, including the service delivery options. So if a member has a need that could be met with either a nurse or through HMA, the nurse assessor is actually going to make sure that they understand their options between those two different services. They're both skilled care services, and they may not know what HMA is. As a, for example, they may think their only option is to have a nurse, a stranger, come into their home to provide their skilled care. And the nurse assessor is going to explain and educate and provide that information to them so that they understand that they have other options. If they have a family member that, for example, would like to provide those services. They're going to collaborate with the member around each benefit and the options. So explaining the pros and cons and helping them understand where it might meet their needs or maybe where it doesn't, because not all services meet the needs of the individual or the delivery options. And then they can help with a recommendation about which benefits and service delivery options will best meet the member's needs based off of the assessment. Next slide, please. Okay, so how is the recommendation being used? For long-term home health and private duty nursing, the recommendation is going to be used by the utilization management vendor for their medical necessity review. So the recommendation is going to be a key component of the review, but it is not the sole determinant. It is not the entirety of the review. There are many other things that absolutely, one, will be required of the home health agency to provide, and two, that make a determination with around whether or not a service is medically necessary. So things such as nursing notes, plan of care required, and any other additional supplemental information that the home health agency has and would like to submit is absolutely part of the entire medical necessity review for the utilization management vendor. For health maintenance activities, HMA, which is again the self-direction option, the recommendation is actually going to be sent to the case manager. So if the nurse completes the assessment, determines the member has skilled care needs, they have the conversation, the member and the nurse determine HMA is one of the best options for them to get their needs met, the nurse assessor will send the recommendation of the number of hours based off the assessment and the conversation with the member of HMA that they need, and then the case manager will take that recommendation to complete the PAR. If additional hours are needed and can be justified through supporting documentation, again, the case manager actually can add additional time for those needs to the direct care calculator, just like a home health agency can do for long-term home health and private duty nursing. So the biggest takeaway here and the biggest point here for everybody to understand is that the nurse assessor's recommendation is very important, but is not the entirety of what is authorized. If there are additional hours needed and can be justified, absolutely, those will be authorized as well. All right, next slide, please. And at any point, Cassie, if you think there's a good stopping point, a place where you want me to pause, just let me know.
Okay.
All right. So what if the needs identified end up being unskilled? So they fall, they actually do not rise to the level of needing even a certified nursing assistant to support them because there's really no medical component to it. The nurse assessor may determine that some of the needs, or potentially even all of them, could be met through personal care or homemaking services. And if this occurs, they will then complete the direct care calculator, which is the calculator where it plugs in the different needs of the individual and the supports that they need to complete those. So think activities of daily living, bathing, dressing, toileting, those types of things. And the results will determine the amount of unskilled services a member may need. So that is being plugged into the direct care calculator. The direct care calculation will then be used by the case manager to create a PAR, which of course is contingent on community first choice eligibility. So members have to be eligible for community first choice. If they're eligible for a waiver, they're likely going to be eligible for community first choice as well. The nurse assessor will then share all assessment results with the case management agency. So direct care calculator, all of the things with the case management agency, so that they can then take that information and plug it into the service plan and all of the things. Next slide, please. An important component here was to understand the difference between the nurse assessor and the URUM vendor. So to be clear, these are two different contracts, two different services, and two different activities that are being conducted. So we are going to have, we do not have it yet. We don't have contract, we don't have a vendor awarded or anything like that yet. We are in the process of this. The nurse assessor is going to be responsible for meeting with the member to discuss and assess them for their skilled care needs. They will then be responsible for developing a recommendation on the number of hours for those needs. They will provide education to members and their families around the available services, including the delivery options. And then they're going to share the assessment results and the recommendation with member and case management agency, home health agency, should they have one. Now, separate and after this is the URUM vendor, who is currently a Centra, and this only applies to private duty nursing and long-term home health. This process is to determine if the service is medically necessary. This process currently exists and is how services are authorized right now. This is the way that things operate, the way things function currently. None of this is changing. The only thing that is changing is that now a member can be assessed for all of their needs at once instead of individually by 3 or 4 different agencies. And so the vendor, again, for private duty nursing and long-term home health only, the PAR is actually submitted to the vendor. Once the nurse assessor recommendation has been completed, the vendor will process the PAR using all of the requirements, all the information that is submitted. It's going to be outlined in the following slide. And then this is the part where if the determination is a denial, partial or full, then an adverse action or adverse determination process is available for members. So this is the only place where a member could be denied services. So this is the place where the appeal process and all of the rights will continue to exist and maintain. Just want to make sure it was important to note that these are two different processes, and that's the reason for this slide. All right, next slide. Okay, so how does the nurse assessor and the skilled care acuity assessment and the recommendation impact the PAR process for private duty nursing and long-term home health? Again, really want to reiterate the recommendation from the nurse assessor is one component of the medical necessity review. It is an important component, but it is one component. The home health agency is going to be required to have all of the things that are listed. They can also have additional information, additional supplemental documentation, absolutely. But they are absolutely 100% required to have a plan of care. Every agency, per their license, is required to have a plan of care for every single member they serve. Assigned physician order, again, also required. These are medical services, and assigned physician order, this is no different, and that is required. Nursing notes and supporting documentation. Nursing notes are also required. If you are providing nursing services, you should be noting and documenting all the services being provided. And then on top of that, what will be new is the recommendation from the nurse assessor and the completed tool or tools. When determining medical necessity for the PARs, the vendor will actually look at everything holistically and take into account all of the submitted documentation as well as EPSDT and all of the pieces there to determine if the requested hours are medically necessary for this individual. Now, that was really fast. Let's go to our next slide, which is questions. And I know there are a lot of questions.
Candace, a couple of themes. Can you talk about a little more in depth on the appeal process? And can you speak to it specifically for health maintenance activities and how someone might appeal that process and then how that differs for long-term home health and private duty nursing.
Absolutely, thank you. So the appeal process is important, and it is absolutely 100% not going away. So to be clear, everybody has a right to appeal when there is an adverse action or adverse determination. The difference between health maintenance for consumer direction, so it's CDOS and IHSS. I just saw that question pop up. So health maintenance activities is available in both IHSS, in-home support services, service delivery option, and consumer direction, service delivery option. So it's health maintenance in its entirety. So there's two different ways that a service might be denied when you're talking health maintenance versus long-term home health or private duty nursing. For health maintenance, what would happen is if, let's say somebody requested 20 hours, but there's really only a documented need for 15. The case manager then would follow the normal process that they do now and provide a 803 to the member, explaining to them what was authorized, what was not authorized, and that member has a right to appeal that. So that for HMA adverse action and that appeal right comes from the case management agency. For long-term home health and private duty nursing, there is a medical necessity review that is conducted by the URUM. If all of the hours requested are not determined to be medically necessary, there will be a denial letter, full or partial, that will be sent to the member, and that is where those appeal rights. So those appeal rights come directly from the URUM vendor. HMA comes from the case management agency, should there be an adverse action. All right, Cassie, there are
There's a lot, so I'm trying to get the themes here. Can you talk about if the home health agency continues to complete any form of an assessment tool in the future state, or does that go away for them?
Great question. Thank you so much. So you are, as a home health agency, you are not required to complete the assessment tool. You are required to assess the individual for their needs and what you are able as an agency to meet for those needs. So for example, you need to understand if you have a certified nursing assistant available to provide the services that are necessary and how many hours and those types of things. And so you are not required to conduct an actual assessment. So the acuity tool that we have, you're not required to do that, but you are required to understand and assess for the member's needs so that you can create the care plan, so that you can then make sure that the services are being provided within scope of practice and the member's needs and all of the things.
Great. Can you talk a little bit about the credentials that we would expect the nurse assessor to have? Would they have any specific type of training on certain populations, et cetera?
Great question. So the nurse assessor is going to be a registered nurse. So they are going to be required to have a license so that they can conduct a clinical assessment. In addition, as part of the contract, we are working to make sure that we have nurses that have experience in working with individuals with intellectual and developmental disabilities, having nurses that have experience in working with children with complex health needs, having nurses that have
really.
Sorry, Kate, I think you came off mute accidentally. Having experience with pediatrics in general, having experience with adults. We want to make sure, because this is for children and adults, we're going to need nurses that have experience with geriatric care, all of the different things. So we are going to require a variety of experience from the nurses within the contract.
Okay. I think I've got like one more kind of theme in there, and then we can open it up. But can you talk a little bit about the referral process? I lost where that question is. From the nurse assessor to all the nurse assessor to the various entities, what kind of communication does that look like?
So, because we don't have a contract yet, we don't have it outlined that the nurse assessor is going to communicate using these three different pathways. Probably not. They're probably not going to text anybody, so that's one that we can eliminate. But what we will do is we are going to work with our different organizations. So for example, case management agencies, we're going to have to work directly with our case management agencies to understand what is going to be the best way for this nurse assessor to communicate with them, to both provide referrals and receive referrals from them. And so that is a process that we are going to rely really heavily on you all and your partnership to better understand what is needed so that we can make sure that those pathways are written clearly in the contract so that they work effectively. So it's going to be referrals both ways with a case manager agency, with a regional medical entity, so Array, with home health agencies. There's going to have to be some pretty clear guidelines on how that works that will be within the contract itself once it's written. Cassie, was that the last big theme? I know there are so many questions.
Yeah, ones we can open it up to who's got their hand raised, and then I do have one more. I don't think we answered Maureen's question in depth enough, so we can.
Great. Okay, so there are 2 hands raised. There are a lot of hands raised, and we are going to start with Nicole. Looks like you have your hand raised first, and then we're going to go back to one more quick high-level theme question, and then I'm going to come back to the other hands that are raised.
Okay, so my first question, well, I'll limit it to one. When we tried to quote unquote streamline the case management, that didn't go so well. It's actually kind of a train wreck. So, and a lot of people's assessments have been delayed, and a lot of people lost a lot of services. And how are we going to prevent that from happening?
Yeah, so great question. Yeah, so what Nicole's referring to is we recently went through a case management redesign process where we really brought together both our community center boards and our single entry points into a single case management agency. Not one person, but there's 15 statewide. And it was, there were a lot of lessons learned around that. And one of the big pieces there that contributed was that there were a lot of agencies having to streamline down into a few. And what this is doing is this is actually something brand new that is starting up from scratch instead of taking over work from 3 agencies, if you will. We are requiring that the vendor has a process and a mitigation strategy for making sure that they don't fall behind on assessments. How are they going to handle the influx? How are they going to make sure they stay up to date? All of those pieces. And so all of that will be required within their contract as we move forward. But I do understand that based off of recent history, there, it's a little nerve-wracking, but it is a different process, and it is something that we are well aware of and planning, and using lessons learned from previous to make sure that we can effectively implement this. Cassie, did you have another thing you wanted me to answer, and then I can go back to
Yeah.
Here?
Can you talk a little bit? Let me see if I can go back to Maureen's question. But generally, it is, how can we make sure that there's going to be enough nurses available to cover the whole state? Are they going to be doing them virtually, in person? How are we going to make sure that they can meet the demand?
Yeah, absolutely. Great question, and one that we get often, and I'm certain we will continue to get because it's a totally fair question. That is one of the requirements of the vendor. So that is going to be in their contract. That is something that as we were receiving bids, they had to explain to us how they were going to meet that demand. How are they going to do this? How are they going to ensure that they can provide an assessment for everybody in the state of Colorado that needs it statewide? So that is part of what we are working on in selecting a vendor in order to make sure that they can meet the demand. The assessments will be conducted in person, so in a member's home and also virtually. So there will be the option to do both. Sometimes it is hard for a family to have an outside person come in because of some immunocompromised situations, and so we want to make sure that those options are available for families as well. Cassie, were there any other high-level themes, or shall I go back to the hands?
One more, I think there was a little bit of confusion and some question about what is the nurse assessor's role with filling out the non-skilled care needs on that direct care support calculator, and how does that impact case manager responsibilities?
Great. Yes. Thank you so much. It's always good to go through and make sure that we're all on the same page here. So as the nurse is conducting the assessment, if they identify needs that are not considered skilled care, so services that are not medical in nature, do not need to be performed by a certified nursing assistant or a nurse, they will then also fill out the direct care calculator, which will help determine the personal care and homemaking needs and the number of hours there. That nurse assessor will then send the direct care calculator and the referral directly to the case management agency, so they have the results of that for them to then submit the prior authorization request going forward.
Great. Let's go to the next person. It looks like Christina has her hand up.
Great. Christina.
Hey, I had a question. Well, I have a couple. They kind of all tie together. The first one was just having this extra step that families have to take in order to maybe get approved for services. Will this be one of those things? If it, let's say we've done everything else, I've worked through again, I've gotten approved for the waiver, and I've gotten approved for certain hours, or my child has gotten approved for certain hours under the current process, and now this new system in place. If there is a delay in getting this nursing assessment, will that delay services? Will services not be able to be approved until this process is complete? Is my first part of that question. And the second part is, will the nurse assessors be able to work with the agencies that are already coming into home and working with members and doing assessments so that families don't have to make other appointments and repeat the same information and provide the same documentation, and in a way to kind of streamline the process and just not have added stress to families?
Great questions. So I'm going to hopefully answer them. I'll try to do it in two parts as well. But if I miss something, please let me know. So around your first question, as far as delaying services, the assessment and the referral, all of that, it's going to be very similar to how it works for your waivers. So you have a case management agency that comes out and provides the level of care assessment and the service planning questions and goes through all that in your home before your waiver expires, usually 90 days before, sometimes 60 days before. This process is going to be the same. So the nurse and the referral and everything, especially for an established member, will receive that referral so that they have that time to get out and conduct the assessment. Additionally, they are going to have contractual requirements to meet those needs. And then again, a mitigation strategy should they need to deploy that. So it should not, there should be no situation where we're running into that timeline. If so, we are going to also have to have a way to escalate those concerns. For your second question, what a great question. Is there a way that we can have them coordinate and have essentially one visit versus having to do two different visits? I think that's a great idea, and that's something that we can certainly look into and see where we can make that work. Because the idea is to streamline and make it easier for you as a member and a family member, rather than more complicated. It's already going to be easier instead of having to have 2 or 3 agencies come out and assess for 2 or 3 different services. But if there's a way that we can have that coordination with a case management agency, I think that's an excellent idea and something absolutely worth looking into.
Yeah, great. Sorry, just adding to that, because I think one thing I think about is right now when my child's in the hospital, right? They have to get reassessed. We do resumption of care in order for them to re-get those services at home. Will the nurse assessor process be a part of that as well? Would that be something that is required to continue services? And how does that work or look like as my child's needs change before that restart period?
Yeah, so change of condition, so such as a hospitalization, a surgery, things like that are also very part of the process. Think about it in the standpoint of right now, if your child is in the hospital and needs to be discharged with nursing services, the hospital discharge planner is going to make sure that you have a home health agency into the home. It depends on the acuity of that, and so there is still what's called the acute home health benefit. So you can have 60 days of nursing care should you need 60 days of nursing care before it transitions over to long-term home health, is what it's called, or private duty nursing. And so you could, the hospital discharge planner is going to help with that process and either submitting a referral to the nurse assessor or hopefully also working with a home health agency to set up the acute home health services in the home should you need those to be discharged from the hospital. So there's multiple components for a discharge planner that they have to be aware of and working on, such as, if they need to send somebody home for with equipment and things like that. Those are all pieces that the hospital discharge planner should be doing. But the idea around working directly with the case manager to have the assessments align makes a lot of sense, and something I really like the idea. So we're going to take it back and see what we can do with that and look into it for sure.
Thank you.
Yeah, thank you. All right, next I have on my list here is Victoria M.
So I have two questions. The first question is rather easy. We saw the link to the notes, but you don't see the question and answers in the chat, and a lot of us are wanting to know, because that seems to be the fastest way answers are getting given. So how do we have access to what's in this chat?
Great question. So what we will do is we will capture the chat and all the responses, and we'll post that online as well. And so we'll have to obviously have a chance for the end so that we can capture everything, and then a chance to answer everything, because we're not likely to get to every single question, but it will be available online, likely like right beneath the PowerPoint or the Google Slides, whatever they are these days. I feel like I'm old because I called it a PowerPoint. It's fine. So they'll be online right in the same area as the slide deck.
Okay, my second question is the question I asked you last time. Because I'm the one to call people out. So I'm going to call it out again this time because we didn't get an answer last time. And that is that things like this always seem to ravel at the seams. That's the past history with it. That's what happened when we tried to reinstate the PARs. Things just really unraveled, and best intentions is also hindsight. So last time we asked, what if this hits July 1st and there's too much bottlenecking coming into the system and things start to fall apart? What are you guys going to do? And your answer was, well, we'll see when we get there. Well, we'll go back to the table if we have to. But running impacted caregivers, I have had so many questions of, what does this mean for my family? What if we're one of the cases that fall through? What if something happens? What if this or that? Because while this is also the services for many people, this is also income for a lot of people that are very scared. And so I feel that families and clients and case managers need some type of reassurance that if this does start to fall apart at the seams, what plan is in place or what can be done to keep a massive dump from happening like it did when we tried to reinstate the PAR?
So great question, and thank you so much for asking that multiple times. And so as a result, what we did was we actually created an implementation plan that has a list of potential concerns and mitigation strategies. So ways that we will mitigate the potential pitfalls, downfalls, unraveling the seams, however you want to categorize the concern or the issue. We have a listed mitigation strategy for that. We actually posted that today so that everybody can see what we're looking at, how we're planning on mitigating, because hopefully we'll only have one thing go wrong instead of 12 things go wrong. But the point is, we've been thinking about all of the different areas. Yes, folks, we will get that posted in the chat here in just a second too. But we've been thinking about the different areas so that we can have a plan in place, a backup plan, just in case. Because as we know, we have to continue to move forward as an agency and as a state and continue to make improvements where we can. But not all changes go off perfectly and seamlessly. Everybody knows that. And so this is our way of really thinking through and coming up with different ways that we will address that. So thank you for asking that question. All right. Next up is,
one question we get, I can try and give a quick, precise answer.
Great.
There's many questions of when will we know who this vendor is. We are in the process of, not me, but internally there is an intent to award letter that is being cleared and going through the processes. We hope to know be able to announce, because there has to be a protest period that goes through. We hope that an announcement can be made in the first week of March of who that vendor is. So we will have plenty of time for that contract to get underway, get executed, and then to give them a ramp up period before implementation starts in July. And one question that I've seen a little bit, Candace, is what does the process look like? If I have a PAR today, when does this start? When should I expect to get a visit from this nurse assessor? Could you speak briefly to that piece?
Sure. I'm wondering if our timeline slide might be helpful for that. Can you go to the next slide just so folks can see this and we can leave this up? So as you can see, it's laid out here, a little bit of the timeline. And the idea is that the nurse assessor is going to begin assessments starting in July. Now, they are not going to do every single person that has skilled care services in July. That's not feasible for anybody. And so the idea is it will be a rolling assessment. And so as long-term home health PARs are reinstated, the nurse assessor will also go live. And so as a agency submits a new prior authorization request for long-term home health services, it will coincide with having a nurse assessor. We are working with the home health agency so they can also understand the timeline for waiver reassessment. So for those of you who are on a waiver, your CSR, your continued stay review, we're going to make sure that the home health agencies have that information so that they can align and time their prior authorization requests with those continued stay reviews, and thus also the referrals to the nurse assessor. So it all lines up is the idea. Okay, next I have Pat Chamberlain.
Hi, Candace.
Hi, Pat.
First, I want to say this is nearly a record, 250 participants in a chat, longer than I've seen in maybe forever.
I would agree. It is probably a record. I feel like.
Yeah. So my question is, it seems, and I know you're aware, there are so many questions, and I think it would be invaluable to take the questions in the chat and try your darndest to get the answers for them and then publish those answers. I mean, I would really appreciate it. I'm sure everybody on the call would. Is that possible?
Absolutely. Yes, we will absolutely take the chat, work on getting the answers to them posted. We'll do it in a log style because I think that's easiest, because then you can see the question and then the answer right next to it. And we will absolutely get that posted.
Okay, and my focal question is, when I put in the chat already, I'm worried about the process. Someone new to with IDD walking in the door, going to receive SLS services, because nobody goes right in the door to DD anymore. And so we're still talking about documenting a disability, proving financial eligibility. They're going to be doing the 100.2, the SIF, the ISLA, the modified task worksheet will be done if they require homemaker and personal care, and the nurse acuity tool will be done if they require skilled care. Is that all correct?
So the CIS is actually going away, so that part won't
Correct.
be
Temporarily,
happening.
though.
So it will theoretically, yes.
Okay,
Theoretically,
that's
but
all.
it is, most people are not going to require all of those different assessments. But the difference here is with the nurse assessor and the acuity tool, instead of having to have the PAT tool and then a long-term home health RN tool and then the PDN tool, so 3 different tools there, they can have one. So it is condensing the number of assessments in totality for a member. Is it condensing all of them into one, including 100.2? No, but it is condensing the skilled acuity assessments down into one.
okay, because this is, we did the Colorado single assessment, that's coming down the road. And it seems like these things should be captured in that in some way. I mean, 27 pages for a new nurse assessor tool. And on top of all those other things, it's simply mind-boggling to me. But how do we lessen the impact to families and members?
Great
to get
question.
Services?
Great question. And, I think it's a process that we continue to work on, Pat. Right now, this already exists. And the way that it works is that a member has to have multiple agencies come in and assess for the different services. And so we're streamlining it down into one. And so the next step is going to be, how do we streamline that even further as we move forward? And so I think that is absolutely a really good future state and something for us to continue to strive for and work towards.
Okay. All right, thank you.
Absolutely. Great questions. Thank you, Pat. All right. I am going to, because I want to make sure that several folks have a chance to ask their question. So there's several hands that are up of people that have not had a chance to ask a question yet. So I'm going to go to Irina next.
Hi, Candace. Lots of questions like everybody was saying, and I've posted a couple more specific on the Q&A. But I think when we come to home health, I think sort of the same question that I'd like to have or to ask, we have regulatory requirements, right? So for home health agency, we receive a referral from a physician to admit the patient for care. 48 hours, we have to do initial assessment and then followed by comprehensive assessment. Probably 99% of agencies that here on the call will say we always do it at the same time. Where does a nurse assessor come into play? Like, how do we create a process that helps the agencies to stay compliant with other regulations that we have to follow? That's one part of the question. The other, let's say if I do get a new referral for the patient, and based on the referral needs, I know this is going to be a long-term home health case, the medication per field, CNA only, whatever. Will the agency be responsible for doing a referral to a nurse assessor? Like, how do we connect? Like, how do we ensure that there's no disconnect between UAM, case manager, nurse assessor, but the agency is the one who's going to be eventually potentially penalized for not following the rules, timeliness, self-assessment, and things of this nature?
So great questions. And I am not going to have all of the in-depth answers for that, but these are things that we're definitely capturing so that we can provide a much more robust response. But in general, if you have somebody that's brand new, they are going to most likely be eligible for acute home health, which means you can start the services and you can follow all the timelines and the requirements, the licensing requirements. And then before, if you know that a member is going to need more than 60 days, so they're not going to recover and be all better by 60 days, which sometimes happens, then you would send the referral to the nurse assessor themselves to then conduct the assessment for the totality of the skilled care needs. Because especially if it's something that's long-term, the member may actually be interested in self-direction services, things like that, and that would be a good education point for them. But acute will remain the same. Those timelines and everything are the same for agencies. And so hopefully that gets you at least a basis. And as I say, we will provide a much more robust response in our posted, not a listening log, but it's kind of a listening log. The responses to the chat, I should say.
Thank you, Candace. And one other question, again, if you don't have the answer, just something to think about. So
Yeah.
Another component to, and I think something to verify, and I'll look into that as well. I don't think that there's certain circumstances we can not fall under acute care, but we have to put them under long-term, but that's to be checked. But
Yeah.
Let's say, for example, an existing patient, right? We have a written plan of care ordered by a physician, and the physician orders, I don't know, let's say CNA twice a week and daily dosing. Again, I'm just throwing it out there. Nurse assessor goes out and determines that based on the nurse assessor's assessment, to different, let's say it's a lower level of care. How do we again, something to think about, how do we manage as home health agency, again, requirement to follow the written physician ordered plan of care versus, an assessment, like do we call the doctor and say, hey, you know, we had an assessment done by nurse assessor, they would like us to decrease CNA services to 3 times a week from twice a day, for example, right? Like, how do we manage that component in terms of, you know, what the physician orders are, what the nurse's assessor assessment is, which always, despite of the tool, whatever, they still have some subjectivity to that, right? Because it's individual clinicians
Right.
going to be assessing the patient.
Yeah, so that is tricky, and that is always tricky no matter what. It's tricky right now, it's going to be tricky in the future because there is no way for every physician to know the different benefits and requirements around said benefits for every single insurance company, right? So they may make a recommendation for a benefit with Blue Cross Blue Shield that Blue Cross Blue Shield doesn't cover, as a for example, or their parameters are different. And so a physician is not going to know. What the physician is going to know is the medical diagnosis and the acuity level of the individual. And so it is not uncommon for a physician to say, hey, we need this level, and we explain the definitions and the way that things work within Colorado Medicaid as a for example, and what's approved through Centers for Medicare and Medicaid Services. And the physician just doesn't, they're like, oh, okay, that, like, as long as they're getting the support and the care, that's all they care about, as long as they are getting their needs met. And so that is where the education piece sometimes can come in with a home health agency. You as a home health agency are required to follow your license and only request services and authorized services that fall within the scope of practice. So you should only be requiring or requesting to provide care that is actually at that level. So you should only be required, you know, and so it's the same idea. So it won't be any different than what it is now for you all around that.
Okay. All right. Thank you very much for taking the time. I really appreciate it.
Of course. Thank you for all of the questions. All right. So we have time for a couple more questions. But then we are going to run out of time, which I am not surprised about. But I want to leave a couple minutes at the end to talk a little bit about next steps and how we're going to continue to communicate with you all and get additional information out, other stakeholder engagement opportunities, specific things that you want to see us cover. So I'm going to take actually one more question, and then I really want to move into next steps, and I want to hear some ideas around areas where you really want us to focus in on the engagement. You want us to focus in specifically on the process from start to finish, from referral to recommendation submission. Do you want to hear, you know, what is it exactly that you want us to focus in on so that we have more time to dedicate to a particular topic? All right, so next I have Katie Wallet. Hi, Katie.
Hi there. I have sort of 2 unrelated questions for you.
All right. Good.
The first is I don't see rulemaking on the timeline at all. And it seems like this is definitely going to impact the PDN rules, but it's also going to really impact 8.7 thousand, the CMRD rules. And it seems like we're going to have to open up and rewrite some parts if we're creating a whole new role that hasn't existed before, in terms of like what specific authority is this nurse assessor given, what duties do they have? And I think that would be a really great opportunity for stakeholding, particularly in this process where stakeholders haven't had a role up to this point. And I also want to really push, like, things in contract cannot be enforced by members or ALJs. And we've all seen that with the ARG contract. We've all seen that with case management contracts, where there are timelines in the contracts. If they aren't followed, there is no role for the member to have any like step in that, right? So I really think like things like timelines that the nurse assessors have to follow really need to be in rule. And so I would love to see a sort of a robust stakeholding process in regards to the rule. And it seems like that has to be starting very quickly if this is going to be in place on July 1st. So that's my first question about rulemaking. And then my second question is, you could talk about what data you're going to gather and on what frequency to measure the outcomes of this new assessor and the tools that are being used. And how can we ensure that that data is published with regularity, and how that will impact the future policy?
So I'm going to start with your second question first, because I really like it. I like the other one too. Let me just be clear. Rules are important. But data. So that is going to be a key area that we are actually working on right now to identify key data points and elements that we need to be collecting to ensure the success of this, right? And so how are we going to know that things are going well? How are we going to know that the assessor is meeting their timelines? How are we going to know that not only are they meeting their timelines, but they're accurately assessing an individual, that members are satisfied with the assessment that they are receiving, the quality of the assessment and the quality of the nurse assessor, things like that. And so those are very specific points right now that we are working on identifying. I think it might be helpful, and folks think about this, of if you have particular ideas of data elements that you think would be best for us to be collecting, send that our way so that we can start thinking about it. Now, obviously we can't collect everything because we may not have the data, or it may not be part of the process or whatever, but the more information, the more ideas that we have, the better that would be. So that is something that we are actively thinking about. We have not identified those certain components just yet, but are working on that. Katie, rules, you're right, we didn't put the rules on here. And that was a complete and total oversight. My apologies. We are going to be running rules. We will actually have to add in these components into the long-term health rules and private duty nursing rules. And so those will be opened up, and we will get those on the timeline as well. The long-term health rules, we've been engaging on those for quite a while now. And so those should be going to the Medical Services Board shortly. But as far as, there's not going to need to be a brand new rule specific just around the nurse assessor, those components will be incorporated into the current benefits that exist. All right, we have 2 minutes left, and there are a lot of hands. And my sincere apologies to everybody. There is no way to get to everybody today. If you have a specific question that you want to ask, please put it into the chat, or there should be a contact slide. Could you go to the next slide for folks? There we go. There is an email box where you can send additional questions, thoughts, ideas, things that you want to make sure that we cover in the future. This is the first stakeholder engagement large meeting for this new process of many. So let me just be clear. We are going to have several different meetings that we can, talk about and present on the information, answer questions. And so what I'd like to hear from you all is, where specifically do you want us to focus next? Where do you want to focus in the future? Where are some areas that after reviewing the implementation plan where we maybe missed a mitigation strategy, things like that. So please send your ideas to the home health inbox. Please put them into the chat here today. And please make sure that we continue to hear from you as we are going forward and working through all of this. I appreciate everybody taking the time to come out today, to ask questions, to submit things to the chat. I believe Pat might be right. 250 folks might be a record. It's probably not a record, actually. When we were doing our pandemic webinars, we would have upwards of 500 folks on those, but that was a whole different time. So thank you very much for your time today. Again, we will capture all of the questions from the chat, provide responses, and get those posted. And please be looking for additional engagement time that will be posted here very soon and in the near future. Thank you all so much for your time today.
Is there a number to leave like a voicemail for questions? Even if it's just like a voicemail box, I'm not sure if that's an option, just for some people who struggle to put questions in writing. I feel like having another accessible option.
There's a phone number that Cassie just posted in the chat, if that's helpful.
Oh, thank you so much.
Yes, of course.